The labor process. There's 4 P's that are involved in labor. We have the passageway, which involves the dimensions of mom's pelvis, the shape of her pelvis, the soft tissues, which include the cervix. And the cervix has to completely efface, meaning thinning out, and dilating, which is the opening, for the fetus to be able to be born. Full dilation will be 10 centimeters. And the other soft tissue is the vagina. We have the passenger, which is going to be the fetus. We have the powers, which will be those contractions, etc. And psyche. The maternal psyche is an important influence on the labor process. We look at the current pregnancy experience, the previous birth experiences, expectations for current birth experience. How well are they prepared for the birth? Is the support of the birth companion there? Are they present? And what's the woman's cultural influence? Nursing interventions, knowledge, and preparation can help break that cycle of fear, tension, and pain that can interfere with labor. Problems with any of these 4 can affect labor negatively. So this involves the passageway. It shows the different structures of the pelvis. This shows the different shapes of the pelvis. The gynecoid is the most favorable. The anthropoid is elongated. The android is heart-shaped. And the platypelloid is the least common, and it will usually require a cesarean delivery. This slide demonstrates the cervix, which shows before labor, early effacement, complete effacement, and complete dilatation. So again, the cervix not only has to dilate, it has to thin out. The Bishop score is something that is used to help determine how ready the cervix is for delivery. How ready is mom for delivery? So true or false? The gynecoid pelvis is the most favorable for a vaginal birth. And this is true. So now we're going to talk about the passenger. First of all, we look at that fetal skull and understand that the fetal skull has not solidified. It's able to rearrange itself and to move to be able to fit through that passageway to make it more passenger friendly, I guess. It's really important in the relationship to labor and birth because it's the largest and least compressible of the fetal body. So sometimes we will see molding as the newborn arrives, and this is the overlapping of bones. It's also important to know what the fetal lie is. And we determine fetal lie according to the fetal spine in relation to mom's spine. Is it longitudinal? Is it transverse? Is it oblique? And fetal presentation, which is going to be the part of the fetus that enters the pelvic inlet first. There's 3 main presentations. We have the head, which is cephalic, and it is the presentation we see in the majority of the fetuses. We have the feet or buttocks, which is a breech presentation. And we have a shoulder presentation, which is kind of uncommon. So different examples of fetal attitude. We have the vertex, we have the military attitude, we have the brow presentation, and we have the facial presentation. Again, it kind of depends on what position that fetus is in as it goes through the birth canal. It will affect labor and delivery. Here's the example of the breech presentations. We have the full breech, we have the frank breech, we have the footling breech, and the double footling breech. So just another slide showing you some of those different presentations. So it's important for us, I'm going to say it's more the doctors that determine the actual presentation of the fetus versus the nurse, although the nurse does have some input to that. But you may see in the documentation LOP or LOA or ROA, etc. And what they're referring to is that first, the left or right, is going to be which side of mom is that presenting part facing. The second part, occiput, or buttocks, etc., that's going to be what part of the fetus is presenting. And then third, that posterior, transverse, or anterior is the presenting part to the mom's anterior or posterior side, or is it sideways? Something else we look at is the station of the baby. So we look at mom's ischial spine and then determine where is the fetal presenting part in relation to that ischial spine. If it's 0, the presenting part is at the level of the ischial spine. If it's a minus, then it's above the ischial spines. If it's a plus, it's below the ischial spines. So just another picture to show you that. So question, fetal attitude refers to the relationship of the fetal parts to each other. Which fetal attitude is most favorable for a vaginal birth? And that will be flexion. We want to have that head flexed. So now we look at the powers. The primary powers of labors are going to come from involuntary uterine contractions, which serve to help efface and dilate the cervix. Technically, the uterus could deliver the fetus without mom providing any pushing. Maternal pushing efforts will supply a secondary power during the stage of labor. The contraction pattern, we look at the frequency, duration, and intensity. We also need to have that resting interval because those periods of relaxation between contractions allow the fetus to reoxygenate and provide momentary relief for a woman. So if you look at this slide, we have the beginning of the contraction to the end of the contraction. That will be the duration. How long does it last? And then the frequency is determined from the beginning of one contraction to the beginning of another contraction. The process of labor is defined as the process in which the passageway, passenger, powers, and psyche work simultaneously to accomplish birth. And a problem in any one of those components can negatively affect the duration and the outcome of the labor. So there's no single causative factor of labor that's been determined for onset of labor. It can result from a combination of several maternal and fetal hormones working together, such as progesterone, oxytocin, prostaglandin, and fetal cortisol. Anticipatory signs of labor, in other words, if mom starts seeing these things, then she can anticipate labor starting in the next few hours or next few days. There may be gastrointestinal disturbances. The mucus plug begins to be released. She may experience lightening. She may have those Braxton Hicks contractions, that sudden burst of energy or nesting. And there may be some cervical ripening going on, along with effacement and dilatation. So these are different signs of labor that mom may see. It tells when it will occur, what's happening with that sign, what mom may see, and what mom should do. And the process of labor. How do you tell the difference between true labor and false labor? And I'm going to give you just a little tip. With the process of labor, mom is going to have contractions. They can either get stronger, they can get longer. Well, ignore that. I can't remember the third one. I'm so sorry, but I will give that to you in class, I promise. So again, figuring out contractions, we need to know the duration, we need to know the intensity and the frequency. So if mom calls saying, I'm having contractions, these are questions you need to ask. Induction and augmentation of labor will use artificial methods to stimulate uterine contraction. If a woman's body is not ready for labor, or the cervix is not ripe enough, it doesn't meet those Bishop score requirements, induction might be unsuccessful. Cervical ripening might be done prior to induction to help improve the chance of the augmentate or induction working. So again, that Bishop score will assess the status of the cervix as to how favorable it is for a successful induction. And we recommend at least a score of 6. Augmentation means that labor has started, but those contractions are just not really effective. So we're artificially stimulating or strengthening uterine contractions that have begun naturally. Examples would be rupturing the amniotic sac, uterine contractions that begin and then stop, or they slow down in frequency and strength. An amniotomy is usually performed in conjunction with induction and augmentation of labor, or to help allow fetal monitoring. It can be used to initiate labor. An amniotomy is performed using a plastic hook that perforates the amniotic sac. It's important to place 2 or 3 pads underneath mom from the waist to the knees, and or a towel to help absorb some of that amniotic fluid. It does place limitations on the labor because mom now has to deliver within a specified time frame. It also increases the risk for infection. The physician is the one who will do this. If it's done too soon, the umbilical cord can prolapse. In other words, it can pass into the vagina prior to the fetal head descending, which would then cause compression of that cord and a lack of oxygen getting to the baby. Rupture of the amniotic membranes can have an adverse effect on fetal heart tones. Basically, what the amniotomy does is it removes that cushion between the cervix and the fetal scalp. So now that pressure of the fetal head, it slams down onto the cervix with each contraction, and it creates fetal heart rate decelerations. Prostaglandins can be used to ripen or soften the cervix. It can also cause it to begin to efface and dilate depending on how close to delivery mom was to begin with. If the cervix is ripe, it's more likely to dilate. Prostaglandins are placed next to the cervix once or at scheduled intervals until labor pattern is established. It can also be given orally. Some of the different ones that are used are Prepidil, Cervidil, or Cytotec. Cytotec is a pill and it's an off-label use. It's one of those medications that's used for peptic ulcer disease, also known as misoprostol. It is an intravaginal procedure. Mom has to be placed on the fetal monitor. We get vital signs every 15 minutes. She has to lay flat for 1 hour and remain in bed for the second hour, but now she can raise the head of the bed. There are some mechanical methods that are available, such as Lamisil and Dilapan, which are mechanical methods. They are put at the cervical opening and they absorb water in that cervical canal. They begin to swell, and then that gradually dilates the cervix. And I don't know if you've heard the term stripping the membranes. This is during a vaginal exam where the physician will insert a finger into the uterus through the cervix and runs the finger between the amniotic sac and the uterine wall. That's called stripping the membrane. So it separates the amniotic sac from the lower uterine wall. And sometimes that will stimulate labor. Oxytocin is the medication that is often used. It is given IV piggyback, so it can be stopped quickly if necessary. We start out slowly and then gradually increase it to stimulate uterine contractions and increase the frequency. Uterine activity, fetal heart rate, and fetal heart patterns have to be monitored before, at the start, and throughout labor. Oxytocin can cause hyperstimulation. Hyperstimulation can cause fetal distress if it's not reversed. If that happens, we have to turn the oxytocin off, and it may require some of the tocolytics, which are medications that promote relaxation of the uterus. Terbutaline or breathine can be given subcutaneously or orally, but the action is slower if it's given orally. With prolonged administration of oxytocin, the uterus can become desensitized to oxytocin. So, in other words, it no longer is working. And once labor has reached the active phase, usually it's self-sustaining, and increasing or even continuing the oxytocin may not be beneficial. So indications for induction: if a pregnancy is putting the woman or the fetus in jeopardy, but only if the delivery of the fetus can wait the length of the induction process. Other reasons for inducing labor: we may have intrauterine fetal growth restrictions, maternal fetal blood incompatibility, premature rupture of membranes, post-term pregnancy, chorioamnionitis, which is inflammation of the amniotic sac, hypertension that's associated with the pregnancy, or maybe it's a chronic condition, or maternal medical conditions that worsen with continuation of the pregnancy. Induction for convenience is not indicated or recommended. So oxytocin, once again, it's a uterine stimulant. It is a natural hormone, but it is available in a synthetic form that can be given IV or IM. It's contraindicated with allergies, a hypertonic uterus, uterine prolapse, or any time a vaginal delivery is contraindicated. Adverse effects: it can cause hypo or hypertension, chest pain, headache, dizziness, nausea, and vomiting. Again, monitor vital signs, contractions, and fetal heart rate, and decrease if we have hyperuterine activity. So this is a slide that just shows you the cardinal movements as the fetus begins to deliver. So usually we have them in that lateral position. They begin to rotate and turn where the face is facing downward during the descent during the birth canal. As it moves through the birth canal, it begins to extend that head. We have that full extension as the head is delivered. After the head delivers, then the baby tends to rotate until that first shoulder has delivered, and then the second shoulder will deliver. So we have 4 stages to labor. The first stage, we have dilatation, but in that stage we have 3 phases, which are the latent, active, and transition. The second stage is the birth. The third stage is delivery of the placenta, and after delivery of the placenta, we do look at the placenta. Did it come out with the shiny side or the fetal side first, or did it come out with the maternal side first? We look at, then the fourth stage is the recovery stage. So these are the stages of labor in a different slide for you. This is what the contractions tend to look like, what the cervix tends to look like, and the position of the baby through the different stages of labor. This is just a visual to show you what the opening of the cervix is like with the different dilatations. Sometimes it's necessary at delivery for mom to have an episiotomy. It's a surgical cut by the healthcare provider to enlarge the opening of the vagina. The healthcare providers will cut if they feel like mom is going to tear with delivery. In other words, the vaginal tissues are not going to stretch enough. They think it's easier to repair a cut than it is to repair a laceration. So the need is determined just prior to delivery. Labor is going to affect mom in much the same way as vigorous exercise does. Heart rate, cardiac output, and respiratory rate will increase excuse me, to meet the body's increased oxygen demand. The other systems, especially the gastrointestinal and urinary systems, are also affected. Mom may have nausea, vomiting, which increases her risk of aspiration due to the slowed gastric emptying. Urinary retention, which is caused by pressure on the urethra. We usually will allow mom to have clear liquids unless there's a high likelihood of a cesarean delivery. If we have that urinary retention, we may have to do a straight cath to remove that urine. Her white blood cell count and urine-specific gravity may go up, and gross proteinuria is never normal, and it always requires intervention. So baby also has some adaptations to labor. There's increased intracranial pressure as the head enters the birth canal. There's temporary interruptions of oxygen. Because of that contraction, it's kind of cutting off the circulation to the baby and causing the baby to hold its breath, for example, and pressure on the placenta. Baby's pH will slowly decrease. We have an increase in surfactant secretion in the lungs due to the passage through the birth canal, and pressure on the lungs helps remove the fluid in the lungs. We may see a caput, don't ask me to pronounce that word, I can't do it. It's basically edema. And we may see cephalohematoma, which is a collection of blood underneath the tissues of the head. We may also see ecchymosis on the buttocks if it's a breech presentation, or the face if it's a facial presentation. Some women may require a cesarean section, and we have different incision types, vertical and the horizontal, or the phalansteal. Indications for a C-section, we have shoulder dystocia. The shoulders are too big to fit through the pelvic outlet. A cephalopelvic disproportion, baby is just too big to fit through. Hypertension, maternal diseases, active genital herpes, some previous uterine surgeries, persistent non-reassuring fetal heart rate patterns, a prolapsed umbilical cord, a fetal malpresentation, or hemorrhagic conditions. Risks of C-section are mainly hemorrhage, infection, or an anesthesia risk. It's generally done with an epidural. We don't often give a general anesthesia with C-sections, so the client is usually awake. We do place a Foley catheter that's usually removed within 24 hours. The support person is allowed to stay at mom's side. There's one obstetrical or neonatal nurse per infant, and usually a second person, and sometimes that second person is like a respiratory therapist. Mom is often allowed to see the newborn in the OR. The postoperative is going to be the same as any surgery, except we also monitor mom's lochia and fundus, which we'll talk more about later. VBAC is a vaginal birth after cesarean. Contraindications would be the classic cesarean incision, or the vertical incision, or other uterine surgery, or maybe she previously had a uterine rupture, or unavailability of having an emergency cesarean section. This is due to a risk. There is one major risk. There is a 1% chance in women who present for VBAC of uterine rupture. So in order to perform a VBAC, the woman has to have that previous low transverse incision, no other uterine surgeries or uterine rupture, because the risk of a second rupture is increased, and the availability to perform an emergency C-section if necessary. And it should be one baby, and it should be head down. Risk of uterine rupture are present for all women who have had a VBAC, but chances increase with aggressive induction or augmentation. VBAC information should be provided to the mother prenatally so informed decision can be made. with all of those advantages as well as risks being provided. The operative team needs to be ready within minutes, usually a 30-minute time frame. And spontaneous onset of labor is ideal because there's a greater risk of uterine rupture if we induce. So close monitoring if we do induce. So a picture of the different types of incisions. During which stage of labor does the actual birth of the fetus occur? That is the second stage. And now for the post-test.